All right. So when I left you last, we were discussing following the medical model of diagnosing people with certain psychological or mental health disorders. Okay, and we do that by observing their features, talking to them about their thoughts and their feelings, and maybe even gauging their memories to see if there's anything missing there, because that could be a sign of something severe psychiatrically, psychologically, or psychiatrically. And the difference between those is chemical versus mood and learning and all that stuff, which we've examined in the past. But we use the DSM-5, the Diagnostic and Statistical Manual for Mental Health Disorders, version 5, for kind of going through and seeing what the clusters of symptoms are to give them a diagnosis, and that label will carry on to help them in the medical sense as to paying for treatment through managed care or their healthcare insurance, getting proper medication. Maybe if they're in an institution or hospital, that'll get them the right level of care that they might need, albeit maybe group therapy or some other evaluation or something, so on and so forth. So that's kind of what we use those labels for. So we're going to dig a little bit more into those labels today. And if you remember from last lecture, I had talked about there are many, many diagnoses, specific diagnoses, somewhere to the tune of 250 through 20 categories. Okay, and we're not going to be able to cover all those within the sphere of this class, but I certainly want to share some of the most important ones that I've encountered with my practice and time in the field. Because many of you that are going into psychology, I know we don't have a lot of people here that are doing that, but you're going to see these not only in psychology, you're going to see these as social workers. If any of you are going to work in like a prison system or work with children or basically work with anybody whatsoever, you're probably going to be hearing about some of these disorders. Okay, so the first one that I want to cover is anxiety disorder. Okay, anxiety category of disorders. And that can look in different subclassifications. And I'm going to go through each one of these individually. But we can see like social anxiety, for example. Oops. We can see separation anxiety, usually in children. Separation. We can see specific phobias. We can see generalized anxiety. I think that's all I'm really going to cover right now. Okay, so within anxiety, anxiety is really specified by our physiological reaction to a stressful situation. So maybe some of you can relate to what I'm talking about with some of these features where, and we talked about those, the sympathetic nervous system being activated. What happens when our sympathetic nervous system is activated? We experience an increase in heart rate. Our breathing might get a little bit labored or shallow, right? Or we to the point where we hyperventilate. We start experiencing muscle tension within our necks or within our bodies. We might maybe fist up our ball up our fists or something like that. We might be hypervigilant of our surrounding, right? We might have ringing in our ears. We might be sweating. All these things happen when we experience anxiety, and that could be for several different reasons. Okay, it could be for because we're getting ready to take a test. We're coming up on the end of the semester, so many of you are probably experiencing anxiety about your grades or about travel this winter, or maybe even classes that you're going to be taking over spring semester, right? Any number of these things can lead to anxiety, and for the most part, that's very, very normal. Now, if you remember last lesson, we talked about diagnosing people and the 3Ds of diagnosis. Does anybody remember what the 3Ds are?
Is deviancy, distressful, and dysfunctional?
That's right. Very good, Noah. Thank you. So distressful, right? Does it cause a person or a person around them distress? Dysfunction. And let's see, deviancy, right? Is it normal, right? So we can look at somebody and say, yeah, they're not exactly acting normal in certain situations. Maybe they're just goofing around. It's making some people uncomfortable, but is it dysfunctional, right? Is it dysfunctional to the point where it's going to cause a reduction of quality of life? And that's kind of how we answer anxiety in that sense. Okay, so I think I used the example last week or last lecture is maybe college students towards the end of the semester will come to me in my practice and say, I'm having a very, very hard time sleeping. I haven't slept for the last 3 days because I just have so much that's due and so many tests that are coming up and I'm worried about my grades, yada, yada, yada. And I'm going to look at their clusters of symptoms there and say, yeah, okay, experienced heart rate, sleeplessness, irritability, all these things might meet the diagnostic criteria for anxiety, like general anxiety or specific anxiety. But panic, actually, that was the other one I wanted to put, panic disorder. Well, what I would look at is, first of all, what's going on in their life? What are they experiencing? Is that a normal level of stress, first of all? And is that a normal response to the level of distress that they're experiencing? And if the answer is yes, we can probably just come up with some ways like relaxation techniques or using mindfulness or something to help them sleep, or even giving them some kind of information on structuring their sleep hygiene so that they can get to sleep a little bit better without worrying about things, right? So that might be an easy fix. Now, if somebody comes to me and says, 30 for the past 3 days, or I'm sorry, the past 3 weeks, I have not been sleeping. I'm about to lose my job because I can't get up for when I need to be there. My grades aren't doing well because I'm not sleeping. What we're going to look at is figuring out a way to get them back on track. And usually, if we're worried about quality of life, this is now probably a more immediate, a more what's the word I'm looking for? Dire need to get them some kind of relief. And sometimes that might be through medication management, like psychotropic medication to reduce their anxiety, or something to help them sleep at night so that their life isn't getting worse because of that lack of sleep. So anyway, that's kind of what we look at with treating anxiety. And like I said, I'm going to mix treatment modalities with what we're talking about as far as these specific disorders. So social anxiety is really the fear of negative evaluation in social situations, right? Being evaluated in social situations. Okay, so we can probably all relate to this, as we don't, many of us may have a fear of getting up in front of people and speaking, right? That's a pretty normal thing. We are a pack animal. We've talked about this in previous lessons. We thrive in numbers. And when we feel like we're ostracized or isolated from our pack, from our people, that's a very frightening thing for us, for our own survival. So it's a very normal thing for us to feel that we're being evaluated because we don't want to be cast out. We don't want to be judged. So social anxiety, certain features of it are very, very normal. Now, where it becomes an issue is where somebody, again, we're looking at dysfunction to the point where maybe they're failing all their classes because they refuse to get up and do their presentations, right? If we're starting to see the quality of life go down for somebody, we now probably have a diagnosable situation here. Okay, so that's really all anxiety is that they're feeling that overwhelming level of anxiety, muscles tensing, right, and sympathetic nervous system activating, and that could be on one-on-one interactions, that could be in dating situations, that could be with somebody with the opposite sex, or somebody that they want to start courting or something for dating, anything, or even getting up in front of a group. So that in essence is social anxiety. Separation anxiety, like I said, happens when we really see that a lot with children. Okay, But we can see that with people as well, especially when we're looking at certain personality disorders where they're codependent on their relationship. But separation anxiety is really marked by those severe levels of anxiety due to removal from something safe, like a parent or something. From, I'm just going to abbreviate, someone or something safe. So say we're taking little Billy. I pick on poor little Billy. We don't have any, I don't think we have any Bills or Williams in this class. But we're taking little Billy to his first week in kindergarten, his first day of kindergarten. And as soon as mom gets ready to leave, he just cries and carries on and tries to run to mom, and just is absolutely inconsolable, right? Pretty normal, I would say. I would say many kids do that their first day because they're learning how to be in a different environment. This is a really new process for them, and it could be frightening if kids aren't accustomed to separating from the home environment or separating from a parent that's been nurturing for them. However, if that goes beyond a month, now we're looking and we're not seeing a reduction in frequency or a reduction in intensity. We could be looking at long-term serious issues that we would probably need to involve a professional to help reduce that so that it's not impacting their ability to learn later on. So that's separation anxiety. So phobias. Phobias are pretty, I would say, I'm not going to say phobias are normal. Fears are normal. Okay. So this is an extreme fear response. I'm going to share with you a story of a friend of mine who, weirdly enough, was in the Air Force. And this person had gotten through their entire career without ever flying. This person was in the Air Force for 8 years and never had to fly. Don't ask me how this person got away with it, but they did. And wound up, anytime this person had to move, all their stations have been in the US, never been deployed. They were in a logistics job, so luckily they were able to not have to deploy or anything like that, but they always wound up in an office job and never having to go anywhere or travel anything as part of the Air Force. So they anytime they went on leave to visit family, they drove with their family, and it was a non-issue. It really wasn't. And then this person got out and they got a really good job with the company where they were traveling to various places and working with the company's client, the private sector. And what eventually wound up happening is their area of responsibility got bigger and bigger. And for a while, this person was driving to each one of these cities and locations in their I almost said their POV, their car, to get to these locations, and sometimes travel anywhere from 15, 16 hours at a time to get there and then come back later that week. And then their area got bigger and bigger to the point where they needed to travel across the country. Well, guess what happened? They weren't willing to do that. And now we're starting to see that quality of life. So that individual, that person was able to avoid flying until it became to the point where they were going to lose their job and their livelihood. Several kids and a nice house. Is this something that they can continue doing or just avoid, because now it's part of their job? So after their boss had threatened to fire them for being disobedient, they came forward and told their boss that they were afraid of flying, and the employer decided to give them some leeway, let them attend therapy for a little bit to overcome this. And it got to the point where this person was able to fly, and yeah, everything was good. It still experiences anxiety with flying, but able to do that and rationalize doing it so that their quality of life doesn't diminish even further. All right, so a phobia is when we avoid things, avoid stimuli or situations to the point where dysfunction is occurring because we're experiencing those extreme fear responses. Okay. The good thing is that phobias are very, very, I'm not going to say easily treatable, but there's a really good practice of doing that called gradual exposure and guided imagery, which we use a lot to help people start. We introduce a relaxation technique. I think I did a breathing and relaxation technique with this group a couple lessons ago, but teaching somebody how to do that and come back to a state, because it's really our physiological symptoms that start revving up when we get excited, when we get experience that fear response. So teaching them to reduce that and then exposing them either to the idea of that situation or maybe even something that represents that situation gradually, a little more each time, and then bringing them down. And then to the point where they can actually be in that situation or close to that situation. For example, I had a client that was afraid to go to public spaces like the grocery store, and this is pre-COVID. But getting them to at least drive up to a Walmart and then get as far as they can, and then have that safe zone in their car where they can practice breathing techniques, but doing that gradually over time until they're able to complete a specific task of being in public, for example. So those are ways to really help reduce phobias. Those are some methods that I use. Generalized anxiety is a little bit of a stranger mix, kind of a blend of disorder, and where the person has feelings of dread and impending doom, like in at least two different situations. Okay, so maybe they're not able to sleep at night because they just feel like something bad is going to happen. Okay, um, and that's affecting them as far as their ability to sleep. That's affecting their inability to their ability to relax, um, which might make them irritable the next day, affect their relationship, affect their job, so on and so forth. So generalizing is impending doom for really no, I'm not going to say no reason, but the reason is very, very, very obscure. All right. It just could be like a chemical reaction, something going on in their brain. It could be something they ate. Even caffeine can show up as symptoms of generalized anxiety if they're not able to relax. I've seen that happen. I've had some of my clients have showed up and they drank half a gallon of Mountain Dew before they went to bed, and the whole night they're just jittery. And it does look like generalized anxiety. However, we would need different situations to add that. So this is really two or more situations. Okay, so it wouldn't just be sleep, it would be several other things. And again, trying to, when dealing with generalized anxiety, I look at figuring out if we can find out situations that trigger them. Is it sleep? Is it talking to people, or every time that the doorbell rings or something like that? What situations are there? So identify the situations, come up with ways that we can induce those relaxation techniques, and or psychotropic medications might be helpful in those situations. But reducing that anxiety to those general situations is often helpful. So panic disorder is the really, it's this is a little bit more pronounced because many people may have had symptoms of anxiety. Most people do. We all experience anxiety in some fashion, maybe not to the level where we're diagnosed, but panic disorder is a whole different, I'm not going to say a whole different animal, but it's a much higher level of anxiety that somebody might experience, to the point where they might feel like they're actually having a heart attack, which is very scary for somebody. Okay. So again, panic disorder, looking at, they're usually triggered by either generalized anxiety, it could be separation, it could be social situations. Okay, so panic disorder or a panic attack could happen for many of these reasons, or even a phobia, for example. Okay, so panic, all these could lead to a panic attack, but panic disorder is when it happens frequently over time, over a long period of time, and there's really, it leads to other things such as avoidance, or even worse, agoraphobia. Now, agoraphobia, literally translated, is agoraphobia. Make sure I'm spelling this right. Agoraphobia is literally translated fear of open places. In most cases, what agoraphobia stems from is a history of having panic attacks. And the person is so fearful that they're going to have a panic attack in an open place or someplace outside of their home that they decide not to leave. So it's not really a fear of open places. It really manifests from a history of panic attacks that they are worried that they're not going to be able to find a safe space quick enough. So that's really what triggers that. Okay. So that's and again, with panic disorder, finding those triggers and using gradual exposure therapy or something like that to help them reduce that. Okay. Any questions on anxiety disorders? Anybody have anything to add? Okay. So another one I want to see how's our time doing here. Another one I want to bring up is dissociative disorders. Now, dissociative disorders are kind of, oops, what am I doing? They're very mysterious for the psychological field because and exactly as it sounds, dissociative, they dissociate, they separate from awareness or consciousness. Okay. So it sounds very Freudian, right? Because that's what Freud talked about, awareness, our subconscious, right? Our awareness, our sub-awareness, things that we're thinking, things that we're feeling, based on experiences of our past or trauma or whatever, that are below the surface that we're not aware of. And that's kind of the direction that dissociative disorders look at. And probably the biggest, the grand poobah of all dissociative disorders, I would say, is multiple personality, which is probably kind of the layman's term, multiple personalities, or called what? Does anybody know the actual term in the DSM?
Dissociative identity disorder.
Exactly. Dissociative identity disorder. Thank you for that. Or DID, identity. Or DID. So that's the actual term for this if you look in, but we know it as multiple personality disorders. And it's really described as somebody that separates from their consciousness, from one consciousness to another. So they have multiple awareness going on in their brain, in their minds, okay? This is most closely associated with trauma. So usually like a traumatic experience, usually in childhood or adolescence, but it sometimes could happen in adulthood. Maybe some kind of violent, either physical or sexual assault could result in DID. Okay, so it's usually due to some kind of trauma or really bad experience where the person, according to Freud, represses those memories and represses that personality and creates a new personality to kind of deal with that pain, and then switch to something that's a little bit more pleasant. Now, I will tell you that dissociative identity disorder is probably one of the most elusive disorders that that we see in the field of psychology as far as actual diagnoses. Now, there's a lot of skepticism, and I'm sure many of you have your own fear or your own theories on whether or not this is a valid disorder. But there is a lot of skepticism surrounding it because there are a lot of people that role play dissociative identity disorder. They fake it. Now, that's not saying that it's not valid, and that's not saying that anybody that's faking it or not actually. I can tell you, I've had probably over 24 cases of people that have talked about that they claim to have multiple personalities, what they say, or dissociative identity disorder. I can tell you with certainty that I have not encountered an actual case of that yet. And that's, again, I'm not saying it doesn't exist, but as a trained therapist, I'm very well skilled in determining whether or not they are actually transitioning between personalities and picking out inconsistencies of their story. And for whatever reason, if they are being inconsistent in that, I don't confront them on that. In fact, part of the treatment is validation. We're validating that person, because regardless of whether I believe that they have true DID or not, they think they do. And they're coming to me because they think that they have this ability or this disability, however they view it, either as a positive thing, cool thing, or a negative thing. So the first thing I want to do for the treatment is validate them and make them feel like their feelings are important. Their thoughts and their personalities, whatever they are important. And then the next part, of course, mixing it in with it, would be a psychodynamic approach. Now, you probably remember that word from when we were talking about personalities. Good old Mr. Freud, right? Sigmund Freud, dynamic models for therapy. And by the way, if I put TX, I put that for treatment, because that's kind of what I write in my notes. So looking at the trauma part of it, where's that coming from? The subconscious level, right? And then dealing with that pain or that trauma in a clinical sense, in a clinical environment, to help them analyze and start processing whatever that trauma is, to reduce the dysfunction of DID. Okay. Within the sphere of dissociative disorders, we also have a couple other ones that are like dissociative amnesia or dissociative fugue. These are, put simply, these are just breaks in, amnesia, breaks in memory, or maybe they're not able to remember an event or a person or a situation with whom they've had interaction. And that's usually caused, again, by some kind of trauma, or it could be something completely innate. They go off on a shopping spree and have no memory of it whatsoever, and then just wake up in bed 3 days later or on the street or something like that. That would be dissociative fugue, if something like that were to happen. And again, it could be a chemical imbalance. It could be really any number of things that we would have to probably get to the root of, and use maybe that psychodynamic model for treatment. Okay, so that's really all I'm going to cover with dissociative disorders. There aren't that many of them, but that's kind of giving you the sense, is just separating from our like a personality or a situation. Okay. Any questions on dissociative, or anybody have anything to add? Okay, so next one we're going to talk about, and ending on this one, are mood disorders. Okay, so mood disorders. When we talked about emotions are things that we feel, and usually an automatic response to something happening either in our environment or a thought that's crossed our minds. For example, if we're sitting down and thinking about how we miss grandma's cooking or something like that, that might either make us sad or might make us feel calm or something like that. Those are internal. Emotions are really, our feelings and thoughts are internal. When we start broadcasting how we feel, either through gestures or through facial cues, or even in the tone or speed or volume of our voice, we can describe those as observable moods. Okay, so in terms of moods, we would look at the word affect. An affect is an emotional reaction to, some kind of situation or happening in their environment. And that's really what we're talking about with mood, is an emotional reaction that's observable. So for example, if we have somebody that is watching an AT&T commercial near the holidays, and maybe you're not at home, but they're showing family getting together and getting on Zoom and talking with everybody and having just a good family moment, maybe having a dinner or something. And that makes us feel sad. That's kind of a normal response. So we might tear up or something. We are in essence showing our mood or affect. Okay. So disorders of the mood are when our mood is, when somebody's mood is incongruent with what should be happening. For example, anybody that might be attending church or a funeral service or a wedding or something, right? That might be a little bit more somber, and then break out in laughter. That's not normal. That's showing a disturbance in emotion. Okay, so disorders of mood would be really a disturbance. Oops. Of emotion ranging from of emotion ranging from anywhere from mild to moderate to severe. Okay, so for example, if somebody's having a great week with their friends or something, and all they want to do is isolate and not be interested in things that they are normally interested in, we can call those probably features of depression in some way. Something is going on that their emotion is not congruent with what's happening in their environment, which brings me to major depressive disorder. Now, major depressive disorder, really, layman's term, we would know this as depression, okay? And it's marked by several really observable factors. It could be withdrawn. They could have, or isolated, they could have loss of interest. So things that they were previously interested in, they are no longer, maybe they like to go bowling or go, I don't know, running every day, and all of a sudden they don't want to do that, or hanging out with friends. Okay, so withdrawn, loss of interest, feeling blue, like just feeling blue all the time. We can experience somebody with major depression might have sleep disturbance, either sleeping too much, I'm just going to put plus or negative, or maybe they're sleeping a lot less, because that we would say that's major depressive disorder with mixed mood and anxiety. Okay, oops, sleep. And so these are just really some of the major ones, major features of depressive disorder. Now we can all probably identify with some of these, especially over the past couple months with the pandemic that's been occurring, right? Almost the past year. So these things might happen naturally, but especially with loss of, like if we experience the loss of somebody, we might experience major depressive disorder because we miss that person. What is not normal is for this to happen at prolonged periods. Okay, so anything like really 4 to 6 months out, we want to start looking at, are these symptoms getting better? Are these thoughts less frequent? Are they able to start acclimating? Because if not, we may have a serious issue on our hands where functionality might start being affected. Their quality of life is now being threatened. It might go down. So we start looking at ways to maybe treat them through cognitive behavioral approach, like changing their frame of mind, or it might be something even medically going on with them. Maybe they have a lack of serotonin. Their serotonin levels in their brain have reduced somehow, or they're not firing enough, and we need to look at biomedical treatment, like medication or something, right? And of course, with depression, and this really resonates not only with depression, but it could be anxiety, it could be schizophrenia, and it could be bipolar disorder, which unfortunately I didn't have enough time today to talk about. But the big outcome that we want to avoid, the big S we call it, suicidal ideation. Now let me talk about suicidal ideation, because this is really a tough thing to not only talk about, but to explain to people how normal suicidal ideation is. Suicide gestures and suicide actions and planning are not necessarily normal, but the thought of not existing in some way is really what suicidal ideation is. Not existing in the world in some fashion, to the point where they are avoiding having to feel the pain or having to feel the anxiety or stress of whatever it is that is prolonged and chronic for them. So it might be financial issues, it might be relationship issues, it might be just stress with school or work that's just ongoing, and they don't have an answer to it. So the best way to avoid that is to escape. Our mind wants to escape. Our minds always need to have an answer for something. We need to be able to see a way out of a bad situation. And if we don't have that answer, we automatically go to this escape idea. Well, what if I just wasn't here? What if I didn't exist in either in the city or in the state or even in this world, which I'll get to in a minute here. So suicidal ideation can happen in really three realms. It could be avoidance, or like completely withdrawn and just imagining not being there. They could have runaway thoughts, maybe just getting in the car, leaving all their wallet behind and just driving, leaving their family, leaving their problems, and just going and being non-existent somewhere. Okay, I know it's not necessarily technically suicide, but it's still the idea of escaping and getting away. And then, of course, there's death. Now, somebody with suicidal ideation might think of not existing. And when we think of not existing, that automatically kind of leads us to, well, taking their own life might be the answer. And it could be just, and within death, we look at three realms, okay? Vague thoughts, planning, and action, okay? So these are called lethality of suicide. Lethality. And the reason why I bring these up, folks, is because, again, when somebody goes to a therapist and they want to deal with some of these thoughts, some people are very, very hesitant. In fact, a lot of people are very hesitant. And the reason for that is because we've stigmatized suicidal ideation. You see it in the news, you see it in shows, our ideas that if somebody comes to you and they have this vague thought of hurting themselves, we might automatically think, well, I'm going to get hospitalized. I can't afford to get hospitalized right now because I got my job, I've got my relationship. How is that going to look on my record if I have to be in the hospital for? So people tend to avoid therapy because they're embarrassed by these thoughts, right? And that could lead to furthering that lethality. So now instead of a vague thought, they're not able to come up with a strategy or plan to fix that issue. So maybe that's progressed to planning, right? Now they're starting to think, well, I can't get help. So maybe if I just take pills or something, or even worse, they might consider hanging or gunshot trauma or something like that. Start imagining what that would look like. Now we've kind of gotten into a little bit more of a serious realm. Still not necessarily hospitalization level, but it could be. And it might be recommended if we're at the planning phase. And then, of course, action phase, when they start actually coming up with a date and a time and arranging their life to not exist anymore. We are now probably at a very extreme phase where hospitalization is not only advisable, but in some cases mandatory. We might have somebody go to the hospital against their will if they're not willing to go themselves and make a plan for safety. Which brings me to our treatment modality for that is like if somebody comes in and says, I've been depressed for the last 6 months. I've been encountering a lot of problems with my job to the point where I really no longer just want to live. I'm going to go through my checklist and I'm going to determine, okay, so you said that you no longer want to exist in the world. I can say you have vague thoughts of suicidal ideation. I'm going to start probing to see if there's a plan. I'm going to see if there's an action or if they have a history of acting on it or planning on it, because that's important too. That means that that might be their go-to. So my point here is that we're going to assess, and we're going to assess the urgency. And if it looks like that there might be a plan, or there's a risk of death, we're going to really consider getting them to a hospitalization to get a better evaluation and maybe more intensive treatment there. Okay, so for treatments, again, it would be just assessment, and based on whatever cause or whatever suicidal ideation precipitated from, it could be bipolar. Bipolar would be a different treatment than anxiety, for example, which is DBT. Your book covered that. But the first phase of suicidal ideation is assessing lethality, assessing exactly what type of ideation they're having. Okay, so the reason why I wanted to end that on this, folks, is because again, this is probably the most extreme outcome for mental health, and it's the biggest problem that we have with mental health, because people that are left untreated for any of those reasons that your book mentioned could get to that level. Doesn't necessarily mean it does, but that's something that we want to look out for. And that's something that you, as professionals in the field, or as family members or friends of people that might be going through stuff, you might be able to detect these things. And if you're starting to see somebody withdraw that used to be part of the group, or maybe they're starting to sleep more or sleep less, or their mood has shifted in a way that maybe they're talking a little bit more dark, reach out to them. Reach out to them and ask them if they're okay. And don't be afraid to ask them about, are you having thoughts of hurting yourself? Because it's a very normal thing for them to think. So that's a very normal thing for you to ask. And you never know, that person might just open up if they were thinking about that and just say, yeah, I'm feeling that way. Thank you for asking that. I don't know what to do about it. It's been going on for a long time. Or maybe they'll say, no, I'm not actually feeling that way. I know better. I have too much to live for. But either way, asking that question is not necessarily a bad thing. You're not going to push anybody into having those thoughts just by asking the question. So just something for you to think about. Okay. Any questions on anything I covered? I know I didn't get through a lot, but I think I got to the end, which is the biggest negative outcome, suicidal ideation. Any thoughts or anything? Okay. All right. So if nothing else, that's all I have. That concludes really everything that I have in the book. So